One of my favorite moments about the conference was that Thursday, and I'm sitting next to my friend Robin, who's reversed her bipolar with a carnivore diet, as we're sitting and watching on stage Hannah Warren, who reversed her bipolar with a vegetarian diet. And I think more people need to know that there's lots of different options. And yes, we may have favorites, but there's lots of different ways to do this for many different people in different cultures and different cuisines. So I love that you explained that. I think that's super, super important and really insightful. I do want to talk about some of your content in your talk because again, it was so different and so helpful. You opened up your talk by talking about diabetes distress, which I think is really interesting and very underappreciated. How much stress there is around chronic diseases and in particular diabetes in particular. Can you tell us what is diabetes distress?
Yes. So again, living with diabetes is a chronic thing. It's not, a fever of 2, 3 days or a back that you pull and it's done in 7 days. It's kind of with you for life in a way. Even if you put it into remission, somehow it can be during its difficult phases overwhelming. And the idea of diabetes distress is that there are negative emotional experiences you can have. It's not depression. So everything else in your life would be going fine. You're not depressed, you're functioning fine. But when it comes to diabetes, you're low on confidence, you don't feel supported, you don't feel understood, you feel like a failure, you feel guilty, you feel like you don't have enough options or resources. And so the creators of this, the founders of the Behavioral Diabetes Institute, Dr. Polanski and Dr. Fisher, they created this scale for type 1 and type 2 diabetes. It's a measurable, reproducible, validated survey where you can actually ask the questionnaire and people can fill it out at home. These are online free tools for clinicians to use. And the patient can understand on a 1 to 6 scale, how big of a problem are these things? There are questions like, I don't feel like I have a doctor I can talk to. I don't feel like my friends and family understand how tough this is. I'm worried that no matter what I do, I'm finally eventually going to get complications of diabetes no matter what. I always feel like my food choices are like a failure. I'm paraphrasing. I don't have the exact words and each word matters. But these are the kind of effects is how bad is this? And the higher the score, 6 being it's a very big problem or biggest problem, and 1 being it's not a problem. The higher the score, this turns into higher HbA1c levels. This turns into more complications, more healthcare costs. And the good news is you can educate people, you can support people, you can bring the score down, and this is mapped to more self-care behaviors in eating and physical activity and movement, in taking medications, in checking your blood glucose, in showing up for doctor visits, and this turns into reduced HbA1c and reduced healthcare costs.
Mm. I remember you made the point in your talk about our recommendations for HbA1c, and it's like on the one hand, you do have like ideal levels that you really want to get somebody down to, but also you have people that have insane HbA1cs, and anything lower than that would be better, even though it's like way higher than ideal. It would still be a step in the right direction. So how do we manage those two kind of truths, and what has the evidence shown as far as like us making recommendations for where somebody's blood sugar target should be?
Yes, and that was always hard, right? Because some of those documents said if the person is more motivated, you can aim for a lower HbA1c. And if they are less motivated, you can aim for a higher HbA1c. And I was instantly uncomfortable when I read this paper because I was like, I didn't see a blood test for motivation. Like, how am I going to measure somebody's motivation? Is it on their face? Is it in their hairstyle or clothes? Or how do we know how motivated someone is? And that could fluctuate from day to day depending on what kind of day you're having. And I get barely a few minutes with these people, and I'm going to make a decision based on that for their whole health plan. So I just didn't feel qualified or confident that this is a good way of putting it. And luckily, a few years later, that document got modified. It's still not perfect, but it's better than what it used to be. Where now they say motivation levels of people are modifiable factors, which means you can make an intervention to change or influence somebody's level of motivation.
Okay. Well, that leads us to kind of something you talked about as well, which I've managed to stay married for over 7 years because I think I've understood this a little better. The fixing reflex. When
Yes.
somebody says they have an issue, my first instinct is to say, great, let me step in and fix the issue. Again, like my wife would come up with a problem and I'd want to step in, and it took a long time to like realize like she doesn't want you to step in. She just wants to express that she's got a problem. You don't have to go in and fix everything. Just listen and validate. Tell us about the reflex, the fixing reflex, and yeah, how many of us with like the kindest intent doesn't really end up helping people very much.
Exactly. And it's so innate that we went into the profession of being coaches and healthcare providers and, committed life partners and parents to help. We want to help. It's a strong desire to help. It's actually a beautiful thing that we want to help and we want to make a difference. It's just sometimes we do it in a way that ends up stepping on people's boundaries or invoking the exact opposite psychological reaction than what we were trying to do. So we're actually sabotaging our own efforts and we're not actually helping the person that we wanted to help. So going with the example you raised about the HbA1c, let's say somebody walks in with a high HbA1c and I see their carbohydrate intake is 250 plus and I want it to be less than 100 and I see their proteins are down. One way for me to talk to them, because I have 5 minutes on the clock, my degree's on the wall, so we know who's the expert here. It's me, right? I'm the smart person, and you've come here to get my advice. So I'm going to tell you is cut your carbs and eat more protein, take these medicines, bye. and and we just somehow think that this is actually going to change a whole person. Like you're going to actually achieve a full behavior change in a person in by doing that much. What eventually almost universally will happen is the minute you say that to someone, they're going to have to arch their spine and say, but wait, I have all these reasons why I need to be at this level. I need to be in the status quo. And it's because what you missed as the helper is this person took the appointment to come see you. They want to get better. They don't want to be sick. They're not wanting to be at 250 carbs and protein deficiency and ill health. They don't want any of that. They just don't know or they haven't thought through. And this precious time with you might be the first chance that they've had in their hectic, crazy, busy life to come here and have some quiet time to think about diabetes for the first time in your presence. So they probably know, I'm probably eating in a way that's not helping my sugar, but I don't know what to do about it. I just haven't had time to think about it. It's overwhelming me. Or I probably know I should check my glucose more often or take my medications, but it doesn't happen. So they're already feeling that. And they also know that if they made these changes, they would get better. So there's like a seesaw, like there's opposite ends of what's happening inside their mind. And they've got this power struggle of me versus me. And you walk into the helper's office, the helper's like, oh, I'm here to fix you. I was born to fix people. And I'm going to tell you what you should do. And what I've done is instead of this being an internal conflict of my ideas about status quo, my ideas about change, the helper has taken away the mic from me and is now talking about change. And well, if they're talking about change, all I have left to talk about is the status quo because that side needs to be heard. Well, that backfires then because now the helper is like, oh, this person's being stubborn. This person's not listening. This person's not interested. This person's not motivated. Oh, I'll give them less difficult or less intense HbA1c targets.
Mm,
Oops. That's very dangerous because I pretty much created that reaction in the person by taking away their voice for change. So this is a coaching technique. This is a counseling or almost like it's actually before it's coaching or counseling, it's a listening technique. It's listening first, you know.
mm,
Are you listening to their needs or desires or reasons for change? Are we even engaging with their agenda? What is it that matters to them? And can we take a walk with them? And where would they like to go? And
mm,
why would they like to go there? And is it okay if I offered some support or advice along the way? That's the fourth, I mean, it's not fixing them. We're taking permission. Would it be okay if I showed you how 250 grams of carb is affecting you versus the 80? But that's only once you've done the preparation of building that relationship where I see you, I respect you. I know you've got reasons for the status quo. I know you want to get better. So let's talk about what's going on.
mm. That's so helpful. Your slides were incredible. I remember the seesaw. kind of slides, and that was really helpful to kind of visualize, to understand this is just human nature. Like we could be talking about anything, any kind of communication works this way. And one slide in particular really stood out to me was you see people's really common like not excuses, like issues, like the gym is too far away, I don't work out often enough, um it's too difficult, it's uncomfortable, I don't like it. And you see the response from the fixer is commonly like, oh well, no pain no gain, or like, well, you really need to dedicate more time to doing this. And you see the problem and then the response, and I can already feel internally inside myself like there's already resistance. And yet we it's so easy for us as fixers to say those things and take those stands. When it doesn't help, it causes that kind of resistance pop up with people.
Yeah, for sure. And I really wanted to hold on to that particular slide. And I'm so glad it stuck with you, Casey, because that was what I was trying to show. Because I knew that this topic means a lot to me and I've internalized it and it's my agenda to talk about it. But it wasn't even on anybody's radar until they heard about it that day. So for me to expect, same way that it's hallucination for me to think a patient's going to walk into my meeting and then just walk out fully transformed because of like 5 minutes of content from my mouth. Same way, it would be inappropriate for me to expect one talk and the whole audience is like just transformed, right? Permanently. It's not how it's going to work. So how do I break it down to meet them where they are as the audience, as the listeners, is I know this is a big shift from where you might be, but do you see why you might be interested in it? And do you see how, if I show you how it's possible within a 5-minute interaction with the patient saying exactly those same example sentences, I think I had 7 or 8 of those, 7 or 8 different sentences mapped where this part stayed exactly the same. The only thing that changed was your response. And how do you think the energy is going to shift so that it becomes visible to you? It becomes possible, tangible, maybe worth learning for your own skills because you've been there. You've been in the situation where you tried to fix somebody and you got resistance and it was draining, it was tiring, it was unpleasant, and you didn't feel like you made a difference. That's not what we're all getting for. We're trying to make a difference and help people. So maybe we were doing something to get in our own way. And I'm really glad that you saw that because the idea was to make it manageable bite size.